there's a health utility called the EQ5D that essentially just looks at very broad, they'll interview patients to say, how do you value your life in a severe form, when you have moderate illness or medium illness or severe illness, but it doesn't get into the sort of details of what actually matters to patients. And those utility scores are also informed by surveys of the broad general public, in terms of how they would value their life living in that health state. And then, as some of you may know, there's been actually some studies lately that show that the general public thinks that people with disabilities live low quality lives, and therefore attribute a lower kind of score to their quality of life than living in a state that's not disabled. And also, I think one of the challenges with the quality is that the evidence that they're using to make a lot of these determinations is coming from clinical trials. So it's not accounting for the clinical knowledge that providers have, because they're, prescribing these medications and see how they work in real time. And that takes some time for that to catch up in the research literature. So I'm not going to belabor this too much. We're actually doing a webinar on Monday at 2 p.m. Eastern Standard Time, if anyone is interested in participating, where we're going to talk a little bit more about a recent project that we underwent to better explain these other similar measures. But I'll pay attention to the first one, the equal value of life year gained. That is another measure that is often used, well, not often used. It is used by the Institute for Clinical and Economic Review alongside the QALY to measure the cost effectiveness of treatments. It also suffers from a lot of the same challenges that the QALY does in terms of not capturing outcomes that matter to patients and relying on some of these biased surveys. And so the real problem with these measures is this math bias that's in the health utilities. The algorithm that's used for determining whether a treatment is cost effective, relying on these survey data, and that has significant implications for vulnerable populations, and is sort of the antithesis of what we're trying to go for with health equity. There's a lot of information omitted. You're not thinking about triggers like food pollution and like pollution and food insecurity, and what impact that has on the expression of disease and illness. So in a nutshell, we all know that different people respond differently to the same drugs. And that's why the Patient-Centered Outcomes Research Institute was created, 10 plus years ago, because Congress wanted to be able to understand not just what works better, but what works better on who. And for many conditions, such disparities are reflected in clinical knowledge, but not in research literature. And so this matters because when you use these kinds of measures as a benchmark for making healthcare decisions, in particular access to healthcare, when you use and this study was done specifically to look at what if you used a QALY as a benchmark for what you would cover. It demonstrated that people with psoriasis, multiple myeloma, small cell lung cancer, multiple sclerosis, rheumatoid arthritis would lose access to the care that they were on and potentially have to switch to a different medication. And the same study was done in Medicare Part B, and also showed tremendous barriers to access to care if a QALY were to be used as the benchmark. So historically, the United States has opposed the use of the QALY. Megan can talk more to the unique Oregon experience, but one thing to keep in mind is that in 2010, when the Affordable Care Act passed, there was a safeguard included in it as part of PCORI's statute that essentially said PCORI is not allowed to use a quality adjusted life year in their work, and Medicare is not allowed to use a quality adjusted life year to make coverage and payment decisions. So that's set the precedent, right, for opposition to use of QALY in the Medicare program. The challenge is that up until recently, that wasn't translated over to other federal programs. Now, Section 504 of the Rehab Act, which was just recently passed, and we actually sent a letter to the Oregon Prescription Affordability Board to clarify that Section 504 of the Rehab Act actually, and this is the law, this is the 1973 law that says you cannot discriminate against people with disabilities in any program, including Medicaid. And the updated regulations now say that you cannot use any measure that discounts the value of life extension, which is a QALY, on the basis of disability to make healthcare decisions. And that same regulation also bars denial of treatment based on a belief that the life of a person with a disability has lesser value. So that's where I think you can potentially capture too some of these alternative measures that similarly do not account for outcomes that matter to patients and people with disabilities. So the entity that does these kinds of cost effectiveness analyses that I think there's a concern about their potential use in these prescription drug affordability boards is the Institute for Clinical Economic Review. It's known as ICER. They conduct these kinds of value assessments, and we have found that those value assessments are often referenced by Medicaid programs, particularly through their P&T committees. The VA also has a special relationship with ICER that they use to develop their formularies, which often results in prior authorization requirements, that kind of thing. And then private plans are using ICER studies to influence their formulary decisions. So this has been a real challenge. I put at the bottom here too that this is an entity that gets a tremendous amount of funding from an entity called Arnold Ventures, which is a foundation. But we'll talk a little bit more about that as we go through. So now the model bills that the states are using to create these prescription drug affordability boards comes from an entity called the National Association for State Health Policy. They've got a couple of different template legislation, but one of them was the Prescription Drug Affordability Board that Oregon passed, and that is now translated into its PDAB activities. Again, NASHB is also funded by Arnold Ventures, so that's kind of where these bills are coming from. And then there's this entity, which is a little bit sort of new to the, I say newer. It's called the Program on Regulation, Therapeutics, and Law, referred to as Portal. Portal has been an entity that is a third-party advisor to the prescription drug affordability boards. We've found them doing presentations, not just to Oregon, but also in other states that have PDABs. We're very concerned because a lot of the early presentations that they were doing to these boards outlined how boards can and should be using EVLYGs and QALYs in their work to value healthcare. We have a lot of concerns, obviously, with the discriminatory implications of that. But they've also now put out some reports that make certain suggestions to states that I think are probably of concern to a lot of advocates. And this is a list of those. They suggest defining rare disease to allow for inclusion of rare disease drugs that treat other non-orphan diseases. So even in states where it may say the PDAB is not to be reviewing orphan drugs, if a drug has even one non-orphan indication, then the states may feel like they can. They also suggest to states to look beyond utilization to allow for inclusion of drugs that treat smaller patient populations. I know that's a real concern for the rare disease groups. They also suggest setting upper payment limits for entire classes of drugs, not just single drugs, which would then leverage patients to drive down spending because they'll incur higher out-of-pocket costs for drugs that are over the reference price. But as we all know, there may be some cases where patients, where certain drugs don't work on patients, and it would be unfair to ask those patients to pay a higher out-of-pocket for those. Also, they're suggesting that upper payment limits use a different kind of measure called an efficiency frontier, which hasn't really ever been used in the United States. And it's something that it often comes up in the context of Germany. We have a whole paper on this. It's really not translatable. So that I think that's problematic as well. And then they also suggest leveraging VA pricing to establish an upper payment limit. As we all know, the veteran in the veterans system, they A, reference ICER, and B, use a closed formulary, which also presents access challenges. They've also suggested a budget impact analysis to measure the impact of newly launched drugs that will have, what impact newly launched drugs will have on state and health plan budgets. So they aren't focused so much on what the benefits are to patients and societies. They're more focused on costs, and that has a lot of potential to promote formulary exclusions. And then for drugs with low quality evidence for therapeutic alternatives, they suggest considering looking for therapeutic alternatives in a different treatment line. You know, I think, this is, and I think, Tiffany, I'll let you speak more to that, because I think this has come up the most with Enbrel. And again, Portal is also funded by Arnold Ventures. And so our specific concerns with Oregon, as we've followed this process, and thank you, Lauren, because you've been so tremendous at sort of keeping us in the loop as to what's going on in Oregon. We're really concerned that the legislation that created the PDAB, when it was being passed, I think we all thought it was a legit quality ban, and it turns out in a recent report that ICER has taken credit for actually drafting this language. It talks about only you may not use a quality to identify subpopulations for which a prescription drug would be less cost effective. I'm not even sure what that means. And then for any prescription drug that extends life, so this gets, I think, to the EVLYG issue. It says you must weigh the value of quality of life equally for all patients. That sort of captures allowing this EVLYG measure to be used. So we think that's how it's playing out. The challenge is that there's, I don't want to jump ahead, but the challenge here is that this is what we think is going on, but there's really very little transparency in the decision-making of these boards, and in particular in Oregon. So while we know that there's an inclination to use qualities and EBLYGs based on the fact that they've got Portal so involved, and Portal is a very pro-quality EBLYG entity, it's just not clear to us. And so, I think that's why we've all been pushing for meaningful engagement, but there's no meaningful engagement requirements or a stakeholder advisory council in the legislation that created the Oregon PDAB. So there's this provision that says the board shall accept testimony, but there's really no requirements around how that should happen, how engagement needs to be made meaningful, how that information is used. So our hope is that, just, by understanding that, and I know with the great work that Lauren and Tiffany and Megan are doing in the state, that there's hopefully we can make some progress. So that is my presentation, and I'm going to stop sharing so others can talk. And I'm happy, maybe, do you want to just do Q&A at the end, Lauren?
Yeah, let's do Q&A at the end. I'm sure Megan has a lot to add about Oregon. So Megan, please introduce yourself and take it away.
Hi, I'm Megan Moyer. I'm the Public Policy Director at Disability Rights Oregon. And I've been involved in the fight against discriminatory healthcare policy for the last 4+ years. But DRO has been involved overall for its existence, which is, nearly 40+ years. But specifically, DRO started to become really concerned, particularly about how Medicaid and the Oregon Health Authority was making treatment allocation decisions starting during the pandemic. We were seeing very, very concerning incidents in which there was clear discrimination against people with disabilities, even though a hospital or a health system was not at crisis standard of care. They were making rationing decisions in violation of the ADA and without actual need to be rationing care. And that kind of triggered the beginning of starting to do a deeper dive with OHA around their own policies. We got heavily involved in OHA's crisis standard of care and sought legal action against that due to its discriminatory nature against people with chronic disease and disability. We then started to look at other Medicaid related issues, which is where we got involved in how Oregon had created what we call our prioritized list. When Oregon expanded Medicaid, this is before the Affordable Care Act, back in 1992, we went to the Center for Medicaid and Medicare Services and said, we want to cover more lives than traditional Medicaid program covers. And to meet the cost neutral requirement, we will limit what care we provide. We will provide less care than Medicaid traditionally provides, but it'll be cost neutral because we're going to cover more lives. And that was controversial at the time. And there were certainly some arguments about how it was going to be done. And originally, Oregon applied saying, we're going to use quality scores. And then we'll, depending on cost neutrality, here's where we're going to cut the line. And anything that scores below that, we just simply won't cover. That was rejected by CMS because of its violation of the ADA. And we would argue also Section 504 of the Rehabilitation Act. And so, so Oregon was told, yes, conceptually, we like where you're going, but you can't use quality. So Oregon said, okay, we'll do our own formula. And largely the oversight dropped there. And nobody really knew exactly how the formula progressed. But it started to become clear due to really some great work by different patient advocates who tracked the prioritization process over time and in their own work fighting to get certain condition treatment pairs covered, figured out that the quality adjusted life year score was in fact a factor, if not a major factor in scoring treatment options for our prioritized list. That became really the basis for effort amongst lots of advocate groups of trying to put an end to this. Oregon did progress over time to stop just using their own formula, which we believe quality played a pretty significant role in, to something called the HERC, or the Health Advisory Review Committee, which is a group of appointed individuals who technically approve the scoring. The truth is they're heavily directed by staff, and staff has an internal process, and that process did include looking at quality scores. And so once we were able to really establish a paper trail that this was in fact happening with how Oregon prioritized coverage, we went and drafted a bill. And that bill barred the use of quality and also really required that the health authority do a look back at its own discriminatory rankings. And so that bill prompted a bit of a legislative fight. And so the first session that Oregon brought it forward, the health authority killed it. They were pretty effective in sowing doubt that it would have all of these negative consequences. We continue our advocacy and became much louder about it, I think, between one long session in Oregon, which is every 2 years, to the next long session, and built some momentum and much greater understanding of, frankly, a pretty complicated issue to explain. I think we all learned how to talk about it a lot better. And thrilled to say that DRO, with caring ambassadors and so many other groups, were able to pass a ban on quality almost unanimously through the legislature. And so, now I think there are real questions about exactly how we're going to make sure that quality is being screened out. But the language we ended up getting did have some compromise. Largely what it says is you absolutely cannot use quality directly in a scoring. You also cannot use research that relies on quality for the conclusion of the effectiveness. You may look at research that makes a tangential reference to quality if it is redacted before being presented. And it has to be redacted not by the staff person who's ultimately doing the recommendation. It has to be pre-screened, so it does not influence the staff person who makes a recommendation. And there is now also, according to the legislation, supposed to be an advisory committee to the health advisory recommendation the HERC. I always get exactly what that is wrong, around disability discrimination and other related issues. So it really was a big victory in Oregon. I think Oregon had probably one of the sadder uses of QALY because it directly influenced the scoring of what treatment was and was not covered. And then it clearly led to conditions not being covered. But really proud that Oregon is now, I think the first state to fully ban the use of QALY in Medicaid.
Thank you, Megan, and thank you for all your hard work on it. You are the rock star on that one and the leader, so really helpful. We had a question, and I'm not sure, FAF? Is that an acronym you used, or maybe something similar?
Did I? Okay, I don't remember what FAF was. I'm not sure.
So I couldn't answer that either. Maybe if you could put more context into how you heard it, we can figure it out. But in the meantime, I'm going to turn to Tiffany to talk about PDABs specifically and where we're at and how we're going to help Oregon get to where they need to be. So, Tiffany, you want to?
It's such a loaded question. Talk about PDABs. It's not only is it so broad, it is literally ever evolving. And so I didn't prepare any slides or any specific bullets because I really just wanted this to be quite genuine. And this is obviously a webinar that we're focused on Oregon. However, I do want to just take it back a step just so people watching and listening understand this is not only happening in Oregon. And the reason that it's important to understand is because these prescription drug affordability boards, or PDABs, they were established starting in 2019 in Maryland. And nobody did anything. They sat and they did their deliberations or conversations. They never actually reviewed any drugs. That didn't happen until Colorado, a different state, right? So I want to just put the context and the bigger picture here of sort of a timeline. And the reason I'm also wanted to bring up 2019 and some of the things that Sarah put on the table with, she had talked about some of our Arnold ventures, and that was on it. And the reason that I bring that up, and I think we all have to think about the broader picture here, is because we know you can Google 2019, the establishment of the Maryland PDAB and who was behind it. It's not a secret that Arnold Ventures was largely behind the forms of these. Portal was mentioned, so this is a group of health economic group who was also given $6 million in 2019 for Maryland to start establishing guidance, which it says specifically on their website of NASHP that guidance was used to create the first PDAB and modeled afterwards. So we can't go forward without mentioning how these were formed, and that this group in particular is extremely anti-pharma, and their groups underneath them are extremely anti-patient organization. And that has put us all at a very, very strong disadvantage. We're catching up. And so I think we just have to say that, and not the typical when I bring up a slide and say, here's what a PDAB is. That is important context here. And I think we need to be talking about that more because of what Sarah said, how it's going to matter in these assessments, because currently they're biased. And currently the way that the review on certain drugs is happening is it is a narrative that the boards are typically making the narrative work in whatever favor they need it to work. And a lot of the points behind the rationalization is based on what you saw with Sarah. So I wanted to just tie that in. And essentially, so now going back to sort of the basics of what these are, they're an effort to try to rope in the high cost of drugs. And I don't care what perspective you're coming from. I am a person living with non-radiographic axial spondyloarthritis. It's a very long word, but it's an autoimmune disease that includes an inflammatory arthritis. I am also the CEO and original founder of AI Arthritis, which is International Foundation Autoinflammatory Arthritis, and leading the coalition called Ensuring Access Through Collaborative Health, or EACH, in the coordinating PIC, or Patient Inclusion Council, which national disease agnostic groups that are working together to really zero in on government drug price affordability reviews at CMS and at the state level. In saying that, I think no matter what position we come in at, we all can agree on one thing. We need to make sure drugs are affordable and accessible to patients. That nobody argues that. It's the how we're going about it. And since 2019 and prior to even establishing that, this is how much traction this other group who has been advocating for these, and they are so far ahead of us, right? So the narrative is spun, and where we come in is where we need to make sure that the data that they're using, the methods that Sarah put forth, that these are not biased, that these are not at population level. These are drugs specifically that are treating heterogeneous diseases, which means, like mine, they are not unique to the individual. They are highly individualized diseases. Comorbidities, 70% in our population have comorbidities, which means that just because you're diagnosed with rheumatoid arthritis, for example, that alone is not going to make you the traditional rheumatoid arthritis patient. There are sub-levels and subgroups that need to be considered that are not in when we put in these. So these prescription drug affordability boards were established to address that. And essentially, they lobby for them. It becomes a law. If it's passed, there is a statute that is different in every state. I will default to Lauren and Megan and the experts in Oregon on what is specific to Oregon, but they are different and they are varied per state. And where I come in and where our coalitions come in particular is making sure that patient voice is heard and it's counted. And that is our number one priority in our coalition at our organization as well. And there has been some work that several people on this call has helped us with over the last week. And I can pause there. And Lauren, I will certainly talk about the survey and the data collection. But is there anything else more specific you wanted me to mention about PDABs generally, of kind of what they are, how they operate? Because I'm happy to do that.
Does anybody have any questions for Tiffany on PDABs? We're going to get more into what we're going to be doing in Oregon in a second here, but if you have any general questions, please throw them in the chat. You know, Tiffany, I think we should kind of preface before we talk about the survey. Let's just step back and preface a little bit about where we're at in Oregon, and that we met with we sent a letter to the Oregon PDAB in December asking for more patient engagement, not just public comment, but true patient engagement. They did not respond. We sent that same letter to the legislators, to Representative Nose and Senator Patterson, and didn't get a response from them, but there were some changes made and they're re-reviewing the drugs. Also have met Madonna from Northwest Bleeding Disorders and myself have met separately with Ralph McGresh, the executive director, and Shelley Bailey, the board chair, and asked how we can help. And basically, we've offered to do focus groups to pull together these patients so that they can actually hear from exact patients of the drugs they're actually reviewing. And we've been told that there isn't time for that, even though we offered to do the work. So then we talked about the survey that they're doing, and apparently the survey was guided by DOJ of what they could actually ask so that it wouldn't be cross HIPAA lines. So I suggested, well, what if we do our own survey? And of course, my phone's going to ring now. And I'm going to let Tiffany take it from there because my phone's not going to stop.
Okay, catch. So essentially, if we kind of, again, wrapping all of this through what Megan was talking about, what Sarah was talking about, and thank you for that introduction to kind of the background here, Lauren, in the need to collect data and the right data. And so what's been happening, and I have not put, thank you for whomever shared, there was a link that just came through with a survey. If you can't access your medicine, let us know here. So I'm interested in clicking on that and see. But essentially what's happened, including in Oregon and the survey that was on the website, is these surveys are not, there's not much thought put to them, and they really are based on collecting population level information with no context. And what that means is they will ask very simple questions like, have you ever had to restructure your monthly budget for groceries, house payments, etc., in order to afford your medication? It's not specific to one drug. It is a very broad, open question. If you have 20 co-payments that are $25 and you have 3 children and a husband or a wife or a partner, and this is how you're answering the question, right? I mean, this is a broader question. It's not specific to this one drug, but that's how they justify, right? And so in the actual, we saw in Colorado, who is the one PDAB who has actually gone through all of their drug reviews now, where we've got Oregon, we're kind of started over, we're in the mix. So we're looking at another state in order to sort of see, because they're all copying each other, right? And we saw some significant issues with the survey that was used in Colorado that ruled the first drug unaffordable. And our organization, AR Arthritis, myself included, have many what are called patient research partners. I've been one for 12 years. I do have college background in research myself. I'm a focus group moderator. And so we took it upon ourselves as patient research partners to say there's something wrong with the survey. And we realized how biased the questions were and how it was not collecting what would be true information that could give them some kind of context on why there's an affordability. So Lauren, after speaking with Ralph, had suggested we could help. We could do a survey, and with doing that, then we could provide some actual data that could be used. And I'll let you kind of weigh in more on that, Lauren. But over the last week, or 2 weeks, we really buckled down, and AR Arthritis with the patient research partners and some researchers, we led the effort to create what we're calling the RIGHT survey. And Sarah and Lauren have been, and some of the other members of the Each Pick Coalition have been wonderful in helping review. And I'm proud to say it is launching on Monday. So we worked so hard to make sure all the right questions are asked, that this is not biased. It can collect people. We're not trying to skew the data to say this is going to be affordable or unaffordable. No, it is honest answers. This is the right way to do it. And we're really excited to have accomplished that. It was quite a feat in a couple of weeks, but we really pulled up our sleeves and knew it had to be done. And Lauren, if you want to kind of fill in the blanks what that means for Oregon.
Absolutely. So thank you, Tiffany, and thank you to you and your team to working so hard to make this happen. So, basically I just said to Ralph and Shelley, let us put together a survey, and if we can get patients to fill it out, will you listen? And they said, yes, they will. So, but it has to go through the right channels. They're not going to post it on their website. It's not going to be, endorsed by the PDAB. So it's up to us if we want to get patient input before next fall that we do this. And so I'm hoping everyone will reach out to their patient groups and pass this on. The next meeting is on the 26th, and they're reviewing Ocrevus for MS. Sorry if I butchered the name. And Shingrix, which is a vaccine. I'm not quite sure why they're reviewing a vaccine. Especially one that if you've ever had shingles, you would say, yeah, I don't care what it costs. But we would love to get as many people as possible to fill that out. If you've had experience with either one of those prior to the meeting on the 26th, and then we've got other drugs coming up. We'll keep you all posted on that. But like really, we just need every patient to fill this out. We ideally like to get patients that are on the drugs that board's reviewing first, focus on those so that we really get some good input there on the drugs that are actually being reviewed. But of course, we are not going to turn down anyone if you are on drugs, because this is just the beginning. This is going to go and go and go. Every year, they're going to put up another list of drugs until they get done with them. So, like, we're not, just because someone's drug is not on this list doesn't mean you don't have to participate. Current hepatitis drugs aren't on the list, but I had to participate.
I want to clarify too, one thing and then build on what you just said about everyone participating, Lauren, is that the survey we're going to put out Monday is specific to it's worded in a way that if a drug is already for review. We are doing a second version for and it'll be very similar questions. It has to be worded a little bit differently and maybe some variation in question that will be if you want to report a drug, and also if you want to report the drug is affordable. Why do we have to only collect information if a drug is unaffordable? Because we are seeing in these drug reviews that they are claiming that drugs that are actually affordable for most, they're claiming they're really not because of the copay assistance program, that those shouldn't be there, and the list price is the list price. So it's really convoluted. But in saying that, I'm going to give an example as a patient of why it matters for everyone to get involved. So let's say hypothetically, so what happens in a PDAB, okay, is they go through, they do these drug reviews. They're going to, in a very long process that varies for each, they are going to decide if that drug is unaffordable or not unaffordable. They don't actually say affordable. And it's different in every state. In Oregon, they look at a broader scope than they were in Colorado. Colorado, the end point is supposed to be if it's affordable for patients and patients only. Now in Oregon, it's kind of a broader healthcare system, et cetera. So that again is different when you look in each state. But I'm going to just, because we've gone through these drug reviews, let's say, without getting into too many of what happens. So if there is a upper payment limit, a UPL that the state has the authority to set, then they immediately get to say, yes, we're going to move forward. We're going to pick a capped price, not for patients. This has nothing to do with out of pocket for patients. The reimbursement price that's going to be paid, and that then trickles down. Okay, so I use the analogy of a Plinko board. If you know what that is, it's a board with a bunch of pegs on it. And patients sit there every year, sometimes twice a year. We're like this at the bottom, right? Is my drug going to make it through? Am I going to get kicked off? This happens to if you're a person who is on an expensive drug. This happens, or not even happens all the time. And what will happen is if the drug goes through the same Plinko board, right? Goes through because it's going to go through the same system, no matter what. When they're done, the board is done. Once they make the decision, then what happens in the insurance company and the PBMs, it is on their plate now. And the advantage is for the payers or the PBMs, because now they have this one price. Now, are they going to pass the savings down and it trickle down the Plinko board? I mean, that's you to decide. They're not really known for passing on the savings. And then the doctor or the pharmacist may not be able to get enough in rebates to be able to even afford to stock it or afford to prescribe it. Then we get into this weird thing. So either one of two things is going to happen. Let's say it works in that the doctor can prescribe it, the pharmacy can stock it, the drug costs less money. Let's just say that's the scenario they want. For patients like me and patients like you who have one diagnosis and different therapeutic options. So we're not talking about orphan drugs necessarily in this. We're talking about when you have more than one drug. If that is now the least expensive, guess what? You are getting non-medically switched. And that means that if your drug was not on review and that one was for rheumatoid arthritis or whatever it was, and that now is the least expensive, I'm getting switched to that drug. And that's not fair because I want my drug. That's why it matters. So I just had to say that because it's true. That's why it matters to me. So.
Absolutely. It's why it matters to everyone. Michael and Robbie had asked about PBMs, and Oregon decided early on that they were going to leave that to the PBM legislation that just passed, and that Rob knows is setting up a PBM task force to deal with PBMs. So they're not taking that into consideration in their deliberations of the cost of drugs. But what they are doing, and Tiffany briefly mentioned this, is they really are looking at it as, is it affordable to the state? And that's a big difference. Affordable to the state versus affordable to patients is two different things, because they can do a lot of these things and make the drugs much more affordable to the state. And as Tiffany said, it means we're going to lose access to drugs because they're not going to be available. So,
yeah, and I would just chime in. I think one of the things I really appreciate about the survey is I think it attempts to kind of get at the affordability issue, because different patients will have different affordability challenges depending on how they're covered. And to date, these PDABs don't really deal with that, right? They make an assumption that there's, because there's no way for them to know what the actual price is in terms of what the negotiated price is for these different payers. And I appreciate, Tiffany, how you talk about, does this necessarily translate into helping patients in terms of their out-of-pocket costs? And that it doesn't necessarily. It may benefit the payer, but it's not necessarily going to benefit the patient in terms of their own out-of-pocket costs. So I think that's another place where there have been concerns raised, and the at least to date, what I have seen from boards, not just in Oregon, but all over, there's very little understanding and recognition of how this works, right? The board members themselves don't seem to understand it, and that's been, I think, a real challenge to overcome.
And I think that's, really the point here is we're not against the PDAB board or anyone on the PDAB board. We're really not. We just want to help make the process right so that they're really hearing from patients, and we're there to help and make sure that the patient voice is included in this. And again, I hope everyone on here will share the survey with all of your fellow colleagues and the people you work with, and make sure that we get it filled out. The more people that fill it out, the better. I know they want to hear directly from Oregon patients, but I just say the more, it doesn't matter, they need to hear, and they need to, get that sort of nuanced data that they're not hearing now. So, did everybody, I thought the question that was in the Q&A about PDABs networked in a meaningful way, and Sarah, you sense they kind of share it, but is there, Tiffany, do you know of, is there a networking of the different PDABs where they're all having conversations?
There was a conversation about 2 months ago during one of the Colorado board meetings where for those who haven't been to these, they're on Zoom and you're watching and they're talking. And so there was conversation saying, we need to get a kind of a coalition together of all of the boards so that we can learn from each other, because they are all the first to say this is a trial and error process, which is kind of scary, right, in itself. Whether they've moved forward to do that, I don't know, but I know that it is something that they're interested in. I do know for sure that they're all watching each other. So they make no secret of that, because they're like Maryland, Oregon, Washington are the ones that are sort of in the next, or in the process, or following next. And they all are watching each other. And I can say that Maryland and Washington, Maryland being next and then Washington further out, they both seem to really want to get this right. And you can hear it in the staff when you talk to them. Not saying that the other ones don't want to get it right. Don't take it that way. It's just they're seeing so much that's like going awry that they're trying to capture all of that. So, I don't know though if they have their little a coalition or anything, but I know that they want to. I also could say I don't know if it's allowed. I don't know what their statute allows.
So Lauren, can you just a point of clarification too, because picking up on this, Oregon, in terms of your process, right? My understanding is that Oregon is doing the affordability reviews saying, yes, this is or is not affordable. And then that culminates in a report in the fall that goes to the legislature. And then the legislature decides whether to act on that report to establish upper payment limits. Am I getting this right? I want to make sure.
We believe so.
Okay.
It's never been done before, but we believe that's the process. Megan, do you have any more insight on that?
Yeah, I don't know if the politics are totally clear of how far they're gonna go.
I think that's the most honest answer that any of us can give is there's so much uncertainty. We can say though, as I had mentioned before, there's some states that have the board has the authority, which those who don't, it's actually a little bit nicer because there's more time. It's a report that goes back to the legislature and then they decide from there. Then you're kind of working with the legislators, you're talking to them, you're explaining your point. Whereas when it's an UPL done by the board, it happens like the week or two after the decision. And then there's a 6 month to a year, whatever it is, process, which is we're still figuring out. So how long it's going to take to actually set that cap for the reimbursement cap. But there's still a lot of unknowns, which is why we have to stay on top of this and make sure we're part of this evolution. Right.
So my understanding in Oregon too, just because in the board meetings, there's just a few minutes dedicated to patient engagement, right? I mean, I know they did these listening sessions, but as I had understood that maybe 2 people showed up at each of them, like there was not robust involvement in the listening sessions, and they don't really have a robust process for engaging patients as part of the board meetings either. So I guess that just underscores to me why it's so important for the survey data, because, from PIPSI's perspective, we don't want them to be relying on these discriminatory studies, like where they're quality based or EBO, or, whatever is being submitted that may be using discriminatory measures. But we always hear, if not qualities, then what? And I think the survey data has the potential to be the then what, right? To really base decisions on people's real world experiences, as opposed to some study done by an academic that was done with a very poor discriminatory methodology. But I'd love to hear from you, Lauren, more about like how you think the engagement has gone, because it seems.
So to me, public comment is not engagement. So you get it 10 minutes and then they added another 10 minutes, but it depends on how many people are on the call. So you never get more than 3 minutes, and that's just public comment. And most people don't understand all the nuances of why their drugs are expensive. And so what we're hoping with the survey is that if patients will want to make public comment, and they'll know how to do it by answering the questions so that it's useful to the board. Because, they get letters that say, my drug is unaffordable, but there's nothing that explains why it's unaffordable. Just my drug's unaffordable. Thanks for doing this. That's fine, except for it doesn't help us get to that answer. So what we're really hoping is by this survey is we can get to those answers. And also ideally, I'd love to see this survey get adopted by all the future PDABs, and that we have one survey for the whole country that's developed by patients, that is for patients, that can help answer these questions. So I'm hoping that if we push this and do it well, that we can make this the model and help all the PDABs, because again, they don't have a roadmap. This is all new. And we're not against lowering prices of drugs. When Gilead came out with the price of Hep C drugs, I hired pedicabs to protest the liver meeting and circle the liver meeting for 2 days. So, I have been known to protest a few high-priced drugs in my life. But, the bottom line, what happened with that high-priced drug is we ended up with all these prior authorizations. We ended up with draconian rules of, in Oregon, you had to have cirrhosis or worse. Well, I'm sorry, you're dead. That's not, there is no worse. So we need to be real here about what is affordable and what's not, and who is it affordable for. And if they're only trying to lower the price for the state, then they need to just be honest and say that.
Yeah, I want to just make another point, circling back to what Sarah had presented earlier and what Megan was talking about too, with just quality and those type of things. So full disclosure too, when we talk about ICER, I am the patient co-chair on the ICER's Patient Council. I am not a champion of the quality. I was picked because of my strong belief in precision medicine and that there's no such thing as an average patient. So I look at this as an opportunity to teach. And I just, so I went, but I am very familiar with the process, and I do see broader perspectives. Now, one of the things I want to just mention of why this survey is important, but why I also am very interested to see what happens from it, is as we know in the reports and the types of things that they're asking these PDABs to look at, these reports that you all are referring to on the research of the clinical trials and the data, is we know even in these ICER reviews or these value assessment reviews, even though they collect the patient testimony, it is not valid information to put into the final report. They do, it's like page 58 or something like that, and it's used, and they do say we believe that payers should take this into consideration, but it's not considered data that can be used as a gold standard of clinical trial because it's real world evidence. And so we really have to think about that as we move forward with our approach. In my opinion, this is about affordability. That's what we have to press with. You can't do a clinical trial on affordability. You need data about what true affordability is, and that has to be our position, because I can see the other side that has masterminded the PDAB coming back and saying, well, it's real world evidence, it doesn't count. So I just want everyone to be prepared for that pushback.
Okay.
Anybody have any further questions? You can either put them in the chat or just tell me to unmute you. If you want to ask a question, I can unmute you.
There was a question in there, Lauren, that you might be able to answer.
So Michael, yes, Shelley Bailey is the board chair, and I met with her and Ralph. Ralph is the executive director, and Shelley's a great advocate, but Shelley's not a patient living with diabetes or, all these other diseases that they're reviewing these drugs on. So, she's great, and we're really excited to have her, and she's actually made a big difference in the PDAB here in Oregon already. But she can't serve as that role of a patient. And again, they've been told that this is a legislative thing, that we need to go back and get a patient engagement board through legislation. And I don't even think that a patient advocacy board is ideal, because then you've got patients with just their experience, not the experience of someone actually taking that drug. I would so much rather see the energy going into getting the answers of people using the drugs that they're reviewing. So does that help answer your question?
I wonder if there's a role then for patients to create the process, just to or better inform the process, because it does seem Oregon's process seems to be, for lack of it seems worse than even in other states in terms of there are not a lot of opportunities. And so I'm just trying to think through, like, is there a way that, I don't know, there could be a process of patients saying, this is what we do to engage our patients. We have experience doing this, like what Tiffany's been doing, and then say, well, and so like just to create it doesn't have to be to tell them what to do with the drugs, but to say, this is a process that we've seen work and that we know, and that we think that we would be then. Because I think too, a lot of patients don't engage in these processes because they don't have a lot of bandwidth, right? So like,
Right.
If they don't know where this information is going, there's no transparency. They don't understand how it's being used. They don't even really understand what's expected of them. Like, why would they engage?
That's also, Sarah, if you Google like PDABs or starting PDABs, all of the advertisements leading up to these and the ones that are in current state, like you look at Minnesota, for example, it all has incorrect information. And they all say this will lower your out-of-pocket healthcare cost. It has nothing to do with that. So why would a patient participate in like if they think it is deemed to be, saying my drug is, affordable or unaffordable? There's a lot of kind of just chaos. What is this? I don't understand. What does this mean for me? So, I think there's just an element of just and I had mentioned this to those who helped create the survey and review it, that I think that just keeping our promotion of it very honest and earnest, and letting them know how important it is to hear all of these perspectives so that patients have a stake in this, and we can decide what happens with affordability based on our voices and our data. And then just lead with that, and then let them kind of trust us that we're doing the right thing here, because it can get really just like, wow, I don't want to participate in this. This is chaos. Like, what is this going to do if I say I actually had somebody in Colorado so upset because they used her words against her in the deliberation, and she was so upset, like, I don't even want to do this anymore. So we just have to be that liaison, be that trusted source, I guess.
Well, guys, we're up on the hour. Thank you, everyone, for participating. Hopefully you've learned something, and hopefully we've figured out a way we can all work together to make a difference in Oregon. And I really appreciate everybody being here on a beautiful Friday afternoon in Oregon. And Tiffany and Sarah and Megan, thank you so much. And Megan, good luck in your race. I know we're not supposed to talk about that stuff, but we want to see you there.
Thank you.
And please, Lauren at Caring Ambassadors, I'm sorry, let me put this in the chat real quick. If you have any questions or don't hear from me with the survey, reach out. Happy to help, happy to get you involved. And I'm always here. So thanks, everybody.
Thank
Have a great weekend. Bye. Oh, and I'm going to put this up on the website.
Megan, it's so nice to see you. All right. Thanks, Lauren.
Bye,
That was
Sarah.
good.
Thanks. Yep.